Good evening, everybody. Welcome to Adoption UK. Thank you so much for joining us tonight. I'm delighted that we have so many people here to listen to Jo's webinar. It's going to be fantastic. No pressure, Jo. If anybody hasn't joined a webinar with us before, welcome. They're set up as webinars, so we can't see you and we can't hear you. So it doesn't matter if you're in your pajamas like a certain person is, who shall remain nameless. It doesn't matter what's going on in your background. We can't see, we can't hear you, so that's absolutely fine. We've got the chat running at the bottom if there's anything you'd like to say. And any questions, if you can pop them in question and answer, and I'll come back on at the end and I shall go through those, but I don't ever say any names, so just feel free to ask away. And I shall come back on at the end. So thank you very much, Jo, and I shall pass over to you.
Oh, it's a pleasure, Claire. Thank you very much for the introduction. So welcome everybody, and my name is Jo Butler and I'm a midwife and also an adoptive parent. And welcome to National Adoption Week, which is super exciting to be involved in this week, and it's nice to see so many prospective adopters that have joined the webinars this week and to tune in to me tonight. So we'll get started. So I've been asked by Claire to talk about life in utero, really, for the baby, and the immediate postnatal experience for those babies who may not remain with their birth families. So I'll start off by just saying some of the topic area is quite emotive. Some of it might be distressing for some of you, and I think it's reassuring, as Claire said, that I can't see you, I can't hear you. So, you know, apologies in advance if it causes anybody any sort of unpleasant emotions. It's not intended to be that way. It's really just looking to share information, to share the knowledge, and to give over some of my experience really as a midwife. And I think sometimes, perhaps if I wasn't a midwife, I'd think, why would adoptive parents or prospective adopters want to hear from someone who works in that area? But actually, looking at things from both sides and with two hats on, it's so relevant. It's so unbelievably relevant to our children's stories well into adulthood. And so hopefully this will give some more information as to why and some of the things that we can do, and hopefully prompt some good discussion as well. So this is pictures of me, all given with permission, and some cards and things that have been sent just about the work that I've done. I've been a midwife for over 14 years, and I've worked in community settings as well as working in the hospital and in specialist roles. And I've done 3 years in higher education, teaching student midwives as well. So we are accountable professionals. We give support and care and advice during pregnancy, during labour and the postpartum period, and also providing care to the newborn baby and infant. It includes preventative measures. So we're looking to prevent ill health and promote wellness. We're also here if things don't necessarily go to plan, so for accessing medical support, appropriate assistance, and we're trained in emergency measures should they be needed around the time of birth. So again, a few cards from families that I've cared for and looked after. I've got plenty and it is the most amazing job. It's a wonderful job. And of course, what we think of when we think about being a midwife, or what society might think of, is that you have this general view of midwives being, good people. I guess we help, we care. You'll be looked after in pregnancy. The midwife will build a relationship with you, and they will look after you when you have your baby and when you go home with your baby. And this is what we see. This is what society sees midwives do. This is what you watch when you watch something on the television or when you read a book. This is the impression that you get. And for some families, this isn't the way that their story plays out. And I've looked at this very much from the point of view of my profession and as a midwife, rather than as an adoptive parent. So I think you'll see that as we go through the slides. Of course, as well as all the other aforementioned roles, one of our roles is very much to do with safeguarding. So the way we work in the UK is local authorities are charged with that responsibility. And they work in partnership with other services to support vulnerable families and children in order to protect them from harm. And it's a widely acknowledged shared responsibility between organisations, so all professionals, and that includes midwives. We offer a universal service to pregnant women and their families, and it is our responsibility to monitor their health and well-being of pregnant women, as well as the unborn baby. And this might include identifying any risk factors where the parents or members of the family may be unable to care for this baby safely. This universal service is really important because it means that we have to be incredibly inclusive in what we do. We come into contact with such a diverse population. We work regularly with parents living in extremely complex social situations, and this is just as current now as it was to me 10 and 14 years ago. Some families are affected by substance misuse, mental health problems. There are learning disabilities. We know that some women are either victims or perpetrators of domestic abuse. There's many young women that I've met who themselves are care leavers, so they may very well have been victims of abuse or neglect themselves in their own childhoods. So this, what we know about all of these things and what the evidence suggests to us is that every single one of these issues has a potential impact on health and well-being of the baby. Okay, so I've put something in here about human rights, which is in essence really the core of what we work with from a legal perspective. So we know that the care of a pregnant woman and what she receives in her pregnancy journey, it has a long-lasting effect on her physical and psychological well-being. And this isn't just about her, this is also about her baby. We know that when there is a lack of respect, so when there are problems with the basic human rights in terms of childbirth, it can lead the woman to feel quite degraded and quite dehumanised. And these will all include values such as dignity, privacy, being treated equally, and autonomy, which means that she has control over her body and how she wishes to conduct and live her life. And we must operate under this, and we must ensure that there are appropriate maternity services that are respectful, that offer respectful treatment during childbirth for all women. So just throwing it out there to you, and please do use the chat function and use the question and answer session, which Claire will filter through at the end, if any of you know out there whether the human rights law actually protects the unborn baby as well. So I don't know if any of you work in this field or if you know the answer. So no, it doesn't. So in human rights, this does not protect the unborn baby. So unborn babies do not have separate legal recognition from their mothers. Women are free to make choices against medical advice if that's what they choose, so long as they have mental capacity. They cannot be forced to accept treatment, which is maybe seen to be in the best interest of the baby. This might include something like medications or drugs in pregnancy. It might include having their labour managed in some way, such as inductions, or the acceptance of a catheter or a drip for labour. It might be actually declining to give birth in hospital. So it may be that the woman chooses that she feels she doesn't want to be there and she wishes to have her baby elsewhere, and you can have your baby anywhere. So you could be in your garden, you could be in a swimming pool, you could be in a hospital, which is what we kind of see as standard. But it's an offer of service. It doesn't have to be accepted, at least not in the eyes of the law. A woman doesn't have to accept postnatal visits from a midwife if she doesn't want to, and she doesn't have to be repaired if she's torn at all, or any other interventions. Now, one of the things I wanted to raise just here was that, having actually worked in midwifery education, the curriculum itself is actually very predominantly adult-centred, and so therefore it's hard, it's difficult, because I can see it from both perspectives. But what this means is that at times you feel that it lacks a child-centred approach, which may be required for effective safeguarding. And this is because the whole essence of really being a midwife is around caring for the woman and her family and putting her needs at the centre of care. And that's so entrenched in the education system and in the curriculum. It's sometimes, you don't view the unborn baby as being a separate entity. It's very much included. They're very much together. So we are grounded in choice and women-centred care, and this is a bit of a balancing act, really. That's where the challenge lies, is because whilst respecting the woman's right to choose how she's cared for and who by, we also have to balance that in the interests of safety. What's also very complex for midwives, and I think you can't really get away from this, I think we have to recognise this paradox, is that we will often build very strong bonds with families, and we face enormous internal ethical conflicts where there is a question of safety. If you've got to know somebody and you've built a bond with them and you have a relationship with them, and you can understand some of the things that they have been through in their life, and you can understand, you can put yourself in their shoes. And actually then there is a question of safety, and it becomes hugely difficult from the midwife's perspective. Sometimes women will want to disclose or talk to you only, so they only wish to tell you about something that has happened to them, and usually it's something personal or something that they feel will affect how others perhaps view their parenting. So it could be something like they'll disclose to you that they've been raped, that they've suffered child sexual abuse, that they are a victim of domestic violence. It may be that they're drinking alcohol, but they don't wish to tell anybody else, they only wish to tell you. And of course this is complex and it's difficult, and not for one second do I want to suggest that a midwife would lose sight of the fact that we have to protect the unborn baby. It is the most important thing, but I think it's still important to recognise there are lots of complexities here. And of course when something is disclosed, we will always need to share this in the interest of safeguarding, and we will always do that with the woman's consent where this is possible, unless she declines to give consent or we have difficulties, and we can still refer irrespective of that. But it is very hard, and what we're really looking at is how likely or unlikely is it that this baby will suffer harm. So we're looking at things that haven't happened yet. This is about in the future. The baby is inside, the baby is in utero. How likely is it that this family, this woman, will be unable to care for her baby when it is born? And that's what I think women find really challenging, is that you're kind of looking ahead at the future and presuming that she may neglect her baby, presuming that there may be some indication there that there may be abuse. So what is really, really important, and again another complex issue, is early help and support. So ideally we want a really early assessment for all women. It should be before 12 weeks. So we call this the first trimester of pregnancy. If you split a pregnancy into 3, you have first, second and third trimesters. And the earlier the better. Most pregnant women will present by around 8 weeks, but there are complexities with women who have quite complex social circumstances. We know that where the intervention is early and where the support is early, we have a good chance of preventing or minimising any harm to the unborn baby. What we need to do is make sure that our communication is really clear, and if there are concerns identified quite early, that we are open and honest about that we're really transparent that we have concerns, and that it may be that we actually have found out that this woman is pregnant through other means. It may be a health visitor, it may be a social worker who's already identified a pregnancy before we actually make this assessment, or it could be that we are the first person to speak to this family. And we have really clear national guidelines around joint working. So where there are concerns of welfare, then we have to put the interests of the baby first, and we know that we have to share that information with other professionals. So this is a bit of a list around when we may consider intervention. So any severe mental illness that may present a risk of harm to the unborn baby. If there's been previously an unexpected or unexplained death of a child and in the care of either parent, where we believe that there may be any adult, so a parent or another adult in a household of which they intend to take the baby home to, that poses a risk. So this may be connected to drug and alcohol misuse, it may be domestic violence, it could be that there's previous criminal convictions, and we have had partners or relatives that have come through our service being Schedule 1 offenders, so that's crimes against children, who have then are expecting a baby themselves or fathered a baby or within that household, which again adds a bit more complexity there, because we then have to also involve the police. There's other circumstances where that would occur, but that would be one example. If any children in the household or the family are subject to a child protection plan, where there has been a sibling who has previously been removed, so it may be under a temporary basis, but they've been in foster care, or they've been removed under either a kinship order, or they've gone to live with another member of the family, or it may be that a previous child has been adopted. If there are any serious concerns about parental capacity of the unborn baby or other children in the household at all, this may include a sex worker, for example. It could be anything that warrants concern about their ability to parent their child. We do consider also some risk factors related to the maternity itself. So a concealed pregnancy would always be a concern. We would always wonder why someone had hidden a pregnancy and perhaps had not presented until quite late on in their pregnancy. And this may be benign. It may be that they really didn't know that they were pregnant, but there could be reasons for hiding the pregnancy. Sometimes we'll see somebody once and then they won't attend future appointments. They won't come to any other antenatal appointments with us or any other service, and there may be a lack of engagement with us or with any of the other health or social care professionals. So this would be deemed to be another risk factor, and we would want to know why that they either couldn't attend or have chosen not to, and what the reasons for that will be, and really looking at the well-being of the unborn baby. Generally speaking, when we're talking about an intervention, this is multidisciplinary. It's so we will have a lead midwife for safeguarding, or it may be a lead nurse within our NHS trust in which we work, which we would go to for support and advice. They may actually help us to complete a referral process. They may actually go to many of the meetings, or you may go yourself, depending on it. It does vary from one locality to another as to how that might work. And some areas, including in the area in which I work, have a designated team which look after vulnerable families. So they will accept very early referrals in pregnancy and look to offer targeted intervention to families where there may be risk there. So there's a few different things that could happen. It could be that the threshold for services from social care team isn't met, and so at that time no further action is taken. But of course we would continue to work with that family and work with that woman, and ensuring that things don't deteriorate or that something else changes. It may be that they're referred on to support services. It depends what the issues are. It may be that there's issues there which we could go to the council with regards to housing. There are many charities that we can use. The Salvation Army work quite actively locally where I am, and we also have Home Start, which may go in and see a family and support them on a low level. And at the moment, at least currently, in some areas we have the Family Nurse Partnership, so they work with vulnerable families where they're typically under 21, and they will work with them for around 2 years during pregnancy and then afterwards. Where there is a referral that is accepted following a multidisciplinary meeting, then there'll be a designated named social worker who'll conduct the pre-birth assessment. I think that all pre-birth assessments are tricky. There may be some social workers that are listening in tonight. I think there's a limited amount of time anyway, because you have the gestation period, so you have the pregnancy, and that's all you have to assess that family, especially if they're not already known to services. It may be that they've booked late, so it might be that they've booked well after 12 weeks, in which case that window is even shorter. I think there's a lot of well-researched, well-known conflict areas here. Social care teams are incredibly busy with very high workloads. There's a tendency sometimes to wait until viability. So viability, what we mean by that is pregnancy that's achieved 24 weeks. We know that after 24 weeks, the baby has got a very good chance of survival. So therefore, avoiding the window in which the baby may be terminated or there may be a miscarriage. But this it goes against what we need to do in terms of supporting the family, because we don't then get that early intervention. Sometimes families will be really difficult to trace, to contact. It may be that you're chasing around for some time trying to get appointments with them. So I can imagine from social care's perspective, this is sometimes very challenging. So for us, any woman who presents with any complex social risk factors that we've mentioned will automatically be referred to a consultant obstetrician as part of their pregnancy journey. And I think it's really important to stress here how vulnerable these families are. We know that women with social complexity are around 5 times more likely to die, either in pregnancy or up to 42 days after the birth. And this is likely to actually be even higher for Black and ethnic minority women. And there's a huge amount of discussion, research and money now being almost thrown at this community. We need to know exactly why and how Black and ethnic minority women are more affected, and not just where there is social complexity, but throughout all of maternity services. And it's a huge issue, it's a huge problem, and we need to get to the bottom of the root cause of why this happens. We know that babies are 1.7 times more likely to be stillborn or die shortly after birth. And again, this is likely to be higher when we have Black and Asian women. Statistically, where there is also social complexity, they may be 2 times more likely to lose the baby. And going back just ever so slightly to the issue around human rights, just interestingly, it was not recently, it was some years ago, but some areas in the States, in America, actually tried to bring in some kind of law around the protection for the unborn baby, and it had quite catastrophic consequences. Basically, people just didn't access care at all. So when we're talking about profiles, and when we're talking about risk factors and the likelihood of somebody actually losing their life, the statistics were crazy. Women just didn't access care, and this is really important here, because actually it's not necessarily the social risk factors that are the problem. It is part of the problem, but actually we could reduce these statistics, we could reduce these figures if women just came to us, if they came and had a normal antenatal experience and they came and had proper care. And quite often it is that we don't see them till late. They may not then attend afterwards. And there are so many issues here. One of the biggest issues is that we know that women with complex social factors are more likely to give birth to their baby prematurely, or it will be of low birth weight. So sometimes this isn't an issue in itself per se, and we know that premature births, so births before 37 weeks, are around 8% actually of the births of England and Wales. But we also know that it's the single determinator of adverse outcomes. So with regards to survival, so whether the baby actually lives or dies, and with regards to quality of life. And we know that they are more likely to suffer in the early neonatal period, the late neonatal period, than after the neonatal period, so after the first month of life. They are more likely to die or suffer with severe illness that may affect their quality of life long term. So this is really significant, and premature births can be prevented in some cases when a woman has access and the right and appropriate treatment and support. So there's a number of issues, and there's so much in social complexity that we could talk about tonight. Really pleased to have seen the webinar on Monday evening regarding development, because that is really tied into what I'm talking about here tonight. So when we're talking about drug and alcohol misuse, which is what I've been asked to focus on, there was a few things that came out of discussions, prior to doing this webinar. It was really about the focus on drug and alcohol misuse in pregnancy and what that experience might look like. So we know that around a third of adults, I say adults, but this is actually women from the age of 13 through to 40. It's around a third of those that are women who access those services. So it's a good proportion. Most of those will have had a termination, a miscarriage, or a live birth, and that their problem drug use has had a negative physical, psychological, social, financial, or legal consequence for them and for people around them. So opioids, so this is a group of drugs, but you probably most commonly know of heroin. Is the most commonly used illicit drug in the UK. But we know that many are polydrug users, which means that they use many drugs. It's not just one, so a cocktail, which may include crack cocaine. It may also include tobacco, nicotine that come in cigarettes, cannabis, and also alcohol. When a woman takes a combination of these drugs, and especially if she's not accessing any support services at that time and that isn't being monitored, then there are huge unpredictable effects to her health, but also to that of the unborn baby, and that is where there is the greatest chance of unpredictable effects. And for women, intravenous drug use greatly increases the risk of bloodborne viruses. So there's some medical complications as well, on top of everything else. They are likely to live in deprivation, experience social exclusion, have medical and mental health problems, and they're also more likely to live with a drug-dependent partner. So we've got lots of associated problems with drug and alcohol misuse. We have physical problems, so such as repeated injection sites, lots of accidental and non-accidental injuries. We have the bloodborne viruses, the management of these and whether they're accessing the right care, the right support, whether they're getting the right treatments, and the nature of using drugs or misusing drugs is the vulnerability there to overdose. Socially, huge increase in unemployment, family breakdowns, real poverty. It's really quite frightening sometimes to see the circumstances in which some families live. Unreliability, and what I mean in terms of this is they have an unreliable life, and it's so chaotic that if they're seeing a consultant, they're also seeing a midwife. They're expected to be having contact with a social worker or support worker around having a pre-birth assessment. They're having phone calls from a health visitor, a number of other professionals. It just becomes too much. They're not the kind of families that are going to have a calendar pinned up on the wall or a diary in their handbag, which is going to list all their appointments in perfect order and colour-coded pen. It's just not going to work like that. Also be heavily involved with violence, perpetrators of abuse, victims of abuse, homelessness, or very vulnerable to losing their accommodation. Prostitution is high, and criminal activity, which feeds into the financial situation because it's around feeding their habit and their need. Huge psychological consequences. This becomes a requirement for everyday living. So every day is dominated by when and how they're going to be able to have the next drink or the next fix, where they're getting it from and who from. Their behaviour becomes really unpredictable, quite irritable, suffer from real chronic anxiety, depression, lots of sleep problems and stress, poor working memory and short-term memory. So it just makes it really impossible to remember what it is that they need to do. Constantly sourcing money for drugs, which means that they have this inability to really provide the basic needs for themselves, for their families, and then lots of other demands that they just really might not be able to manage. And on top of all of this and these associated problems, as well as the drugs and the alcohol, they're now expecting a baby. It's, I think, just for any of us to think about carrying a child is quite complex and quite a lot to think about, and the focus would be on that baby. But yet for them, quite often, sometimes the baby is actually not really the first thing on their minds, or may not be. So one thing about the experiences in utero, that probably the most important thing that I want to get across in tonight's webinar, is that the birth mother and the unborn baby are intrinsically linked at this stage of development. The baby will experience and will feel every single emotional, psychological and physiological state as the woman lives it. And these experiences will form part of their non-verbal memory, and in turn also their identity. And there's not really a place for separating the two. They, at this particular stage of development, they are almost as one. Teratogens is the term in which we use, so this is what we use it's a medical term, which means any substance that may produce a physical or a functional defect to the baby in pregnancy. The duration of exposure, the amount of exposure, and the stage of development are all really important factors as to how this could affect the baby long term. What's also really important is that there's no safe period. So it doesn't matter if somebody's 5 weeks pregnant or if they're 35 weeks pregnant, there is no safe period. And a total pregnancy being 40 weeks, and as I've mentioned, that's split into 3 trimesters. The baby actually is fully formed by 11 weeks and 5 days. So prior to 12 weeks of pregnancy, the baby is actually fully formed. And it's in this early portion of pregnancy that we will see the physical malformations. So this may be features in terms of cleft lip and palate, nose, eyes, ears, any deformities there, but also deformities of the heart, so congenital anomalies, but also maybe of the organs. So it might be that the baby has malfunctioned kidneys or a missing kidney. It could be a number of physical factors, but that will all be in relation to the substances that were used in the early portion of pregnancy. So possibly even before the woman even knew that she was pregnant, when, you know, depending on her lifestyle, it may have been a real time of risk. Also, if she knew she was pregnant, she wouldn't have looked pregnant. So maybe had been deciding or choosing or felt that she had to hide the pregnancy at that particular point. When we move into the 2nd and the 3rd trimester, this is where you then see problems that perhaps might present later in life, so emotional and behavioural problems. There may also be learning difficulties, speech and language issues, reasoning and cognition, problems with things like sensory issues, being hyperactive, that kind of thing, will all come in the 2nd and 3rd trimesters where there has been exposure, where that can be linked. So this is a little bit more complex because it may be that the baby initially looks well and healthy and behaves in a normal way. It may not actually even show any signs of withdrawal, for example, if there has been drug and alcohol misuse. But it may be that it's months or years later where problems are identified with development, and it may be linked back actually to teratogens that were taken in the 2nd or the 3rd trimester. And this is also why prematurity is adds another complex layer, because actually if the baby is then also born early, it's actually technically been born before certain things have completely established, whether it be organs within the body or whether it be connected to brain development. And this will all have a factor, this will all make a difference. So this is quite a complex slide to look at, but we've got the fetus here in the middle, and then various different drugs that may be used or commonly used in pregnancy, including alcohol and tobacco. And I think the thing about drug exposure is that we know that it can produce long-lasting changes in the brain, the structure and the function. And these maladaptations, if you like, are regardless of whether the drugs were illegal. Legal drugs such as alcohol and tobacco and caffeine can have just as much effect on the baby longer term than those which are illegal drugs. So what we consider to be, or what might be viewed as harder drugs like cocaine or heroin. It actually doesn't relate necessarily to longer term development. One thing about this, just notice there's many that cause problems with prematurity, many that cause problems with growth. So we're looking at smaller infants like we've already mentioned. There's many others sort of more longer term, such as deficits in attention or in academic ability, brain volumes, ability to cope, verbal fluency, all those kind of things, they're all there. Neonatal abstinence syndrome is something that people might have heard of, and it's associated really with women who take opioids in pregnancy, and it's a way of monitoring the baby afterwards to look for withdrawal symptoms, and I have got more information on that as we go through. One thing I wanted to mention here is that it's also really important to know that there are protective factors. So despite all of this going on in pregnancy and these teratogens which have the potential to cause significant damage, we know that this doesn't actually pan out, or this doesn't work out for all babies. It doesn't work like that just because a woman has taken this combination of drugs at this particular time. They're not all the same, and partly that is because no woman and no baby are the same, so they will all be affected in different ways. But we know that there are protective factors. So age is a significant protective factor. The older the maternal age, the increased risk of more complications and the effects of the fetus. Hormonal regulation and metabolism are also really important. So even with drug and alcohol exposure, if she has a normally functioning hormonal system and a normally functioning metabolism, then actually the stress actually is reduced on the fetus because her body is actually more able to cope. Where there is no underlying disease, so something like diabetes is quite significant because diabetes affects the way in which the metabolism breaks down fats. So it will also affect the way in which her metabolism works and breaks down the products, so the drugs, for example. And there's also issues around the placenta, which is important. So the placenta, think of that as it's an organ in its own right, but think of it like a filter. Now, all drugs pass through in some way or another in various different volumes, depending on what the drug is. But it will filter out some of the toxins and it will cope. Now, the placenta is implanted around week 7 of pregnancy. If week 7 of pregnancy, actually, she didn't take as many drugs as she otherwise had done, or had abstained on that at that particular time from alcohol, for example, the placenta may very well have attached healthily and normally into the uterine lining, and therefore she might actually have a placenta that was implanted in a normal way, but also that has gone on to function well. And the better the function of that placenta, then the more protective factors that is for the fetus. Alternatively, of course, it could be that was really affected at that particular time, and it could have been that the placenta actually is really morbidly or not attached in the correct way, and that may then significantly affect the growth of the baby. Is going to be what it's going to affect more than anything else. But if it's not had the chance to attach well, then the blood vessels are going to be restricted, so there's going to be less oxygen and less growth factors, but also less development because of that restriction. And she's also going to be more vulnerable to things like preeclampsia in pregnancy because of the lack of blood flow. So there are a number of protective factors as well, and I think that's really important for us to remember and to hold on to when we're thinking about coming from the view of being carers and adopters. So one thing I wanted to address, this has come from the NSPCC, it's fairly recent data which talks about families who are struggling. So around 1 in 5 babies living with at least one parent with a recognised mental illness, 1 in 7 with at least one parent who admits to using illicit drugs, 1 in 8 who lives with at least one parent who stated that their alcohol use was a problem, 1 in 15 who admitted to regularly using illicit drugs, and 1 in 20 where there is domestic abuse. Arguably, you could suggest that some of these rates might actually be higher in some of these categories, particularly maybe domestic abuse, where it just may be that it's not disclosed. And this is a systemic problem within our society, and babies that are born to families who are really, really in need, this will affect many families in society, not just adoptive families, but families whereby maybe they are maybe grandparents, maybe kinship carers. Yes, of course, it can still be foster carers and other people, but it's also the parents themselves, and it's a wide problem amongst our society that's not just restricted to adoptive families. I think that the issue with adoption is that we're sometimes disproportionately affected because we have to think about those families whereby those babies were at risk of removal and why they were removed. So looking at my experience of working with vulnerable families, My personal opinion, so this is just what I have found when I've worked with a number of families, is that they really feel quite judged. They feel really stigmatized in general, and they feel like they've got this label of being kind of a bad egg, or you know, they're addicted, they drink too much, they smoke too much. It's what they do. They're incredibly fearful, really frightened of accessing services, and when they do, they feel possibly that people let them down, because I guess people have let them down a lot. Very little trust. The trust really isn't there with professionals and also with support services. There's still, I think, significant barriers to them accessing help that's appropriate and that's individual for their needs, certainly in terms of pregnancy, because we need it to be earlier, so much earlier. And it's so frustrating when people present so late in pregnancy and you feel like you're then against the clock. Some information I think that's given to them, sometimes from their perspective, they might consider to be poor, or their processes in which they just don't understand. They don't understand why they have to have visits from a social worker. They don't understand why they have to have visits from a health visitor, why someone has to come and look at their life and have it exposed that way, I guess. Lots of communication breakdowns. They often misinterpret. They don't really know what's expected of them, or they'll verbalise in some way that they feel that they've been set up to fail, in that they could never have achieved what was expected of them. Now, certainly from a professional's perspective, but I can only imagine how difficult this must be for a family. Removals are highly emotive. They're really distressing for all involved. And often what I think sometimes is a little bit of a frustration is that actually everyone involved often want the same things. So I think that the professionals really want the family to have time with the baby. They want to have time with the baby. They want the opportunity to say goodbye. And I think professionals want that too. They want them to, and I've certainly always tried to encourage them to, you know, do as many keepsakes as possible. And if they have the ability or the means to have something, a comforter or something that can go with the baby, then to do that, because it's something that they can do positively for their baby. I think from the family's perspective, and I think where this has been the most evident to me, is because we still offer care, and we are obliged to offer care up until, usually most families will be discharged around 2 weeks after having their baby, but for some women this may be up to 28 days. That's within our remit. And if you go to see a woman postnatally who's lost her baby through removal, and you go to see them, and how empty and how distressed they really are, and that on more than one occasion I've had families verbalise to me that they actually wish that their baby had died, because that would have been more manageable, because there is no social acceptance for this. There's no social acceptance for this grief. This grief is too hard, and they would have rather said to the person over the road or the person who's living in the hostel with them that they had lost their baby because it had died, rather than they had lost their baby because it had been removed. There's no understanding for that from their perspective. It's incredibly difficult. I think that in order to help them with the grieving process and to help the baby longer term, I think that writing letters, lots and lots of photos, giving breast milk where this is appropriate, is all positive things that they can do, and that's what I always try to really encourage in our conversations. Something that we can do as professionals, and I think what we really want to encourage the birth family to do, is to really look at those first few hours with their baby and the things that they can do that actually have a positive impact, and that may again act as a protective factor. So skin to skin is something that should be offered to all babies irrespective of risk, as long as this is appropriate to do so, and as long as there's no medical need for them to be separated. We know that this regulates breathing, it regulates their heart rate, improves their tone, their flexion in their muscles, encourages early bonding, and we know that this is really important even for when the plan is for a removal of the baby. It should not be interrupted. We know that they're calmer babies, they're more relaxed, and they're less likely to need intervention to help them to regulate their breathing. They will look to feed sooner, which is really important for drug-dependent mothers, because they have difficulty stabilising their blood sugars anyway. So if we can do this through offering skin to skin and then them to look to feed sooner, this can only help them. And there was something that I looked at. It was a study actually in the paediatric guidelines for Scotland, which said that when mum is dependent on opioids, where she has given breast milk, there is a 50% reduction in the need for the baby requiring treatment for neonatal abstinence syndrome, which is huge, absolutely huge. So again, we look at bonding, we look at attachment, we look at feeding. Some babies will go straight to the neonatal unit. Neonatal abstinence syndrome, which I've mentioned briefly, is a group of symptoms occurring in a baby as a result of the mother being physically addicted to opioids. So obviously the difficulties is that it's designed for this, but the baby may also suffer withdrawal symptoms from cocaine, from caffeine, from nicotine, and even some antidepressants and antipsychotics. Because it's impossible to predict the individual patterns of withdrawal, it's unlikely that the baby will be discharged before day 5. So my experience for caring for these babies, I first experienced this as working as a student, and I looked after 2 babies that were currently on the neonatal unit at that time, and both of the plans in those cases was for removal. It didn't really make a difference that one was a boy and one was a girl, but they stuck with me and they will stick with me forever. But the little boy in particular, he scored very highly for NAS. So his mother was addicted to opioids. She was also on a methadone program, but also took crack cocaine. She also smoked and she drank. They're really irritable babies. The cry is quite distinctive. It's not like a normal baby's cry. Now, obviously newborns' sleep is very fragmented anyway, and it's even for a normal baby, but a baby that's withdrawing will really not sleep for a normal pattern at all, and you'll be very lucky to get anything more than an hour. It would be much less normally. Very poor feeding, very poor sucking. They do have a raised heart rate, which comes up on, which is flagged up when they're monitored, and they do have the appearance of sweating, which is very unusual for a baby. They often vomit. Newborn poo is very watery anyway, it's very liquidy, but this is something quite different when you see it. They have poor weight gain, really to do with the vomiting and the diarrhea and the poor feeding, and something called jitters. So this is muscle spasm, and this is interestingly maybe seen weeks or even months actually later, not necessarily in the first few days, which is where they're typically monitored in hospital. Very rarely, occasionally I've not seen them, but it's reported that there may be convulsions. What's quite hard, and I found really hard caring for these babies, is that they'll require feeding really regularly because of their inability to properly metabolize their sugars. So they need feeding sort of 2 hourly to begin with, then increasing slowly up to 3 hourly, but they don't tolerate the feeds. So they're really slow to feed, may take an hour to feed. They may even pass wind or have a bowel movement in the middle of a feed, which will cause them to cry because it hurts. They'll almost look like they choke on air. They have no kind of coordination with their sucking, really. So irritable. Then after the feed, they'll often vomit or have diarrhea again. So it becomes this sort of cycle of what feels like quite pointless exercises, trying desperately to get this baby to feed, but just can't keep anything in. They get really sore. The skin gets really sore really quickly through frequent bowel movements. So they often cry because they're in pain, and this has to be really well managed with lots of appropriate interventions and barrier creams to help them from stopping it getting that bad. They require a lot of holding, so certainly if a baby is really suffering, they'll require almost one nurse one-to-one with them. And when I was that was my experience, really. My first experience with as a student was really having to be one-on-one with these babies. And then you put into that a mother or a family who are very vulnerable, who are being watched with their parenting, not easily comforted, these babies at all, and just how difficult it is. So irrespective of what's happened pre-birth, whether there's been the opportunity for the full assessment, whether there's been a case conference in pregnancy, we'll always inform the social worker, named social worker or duty social worker when the baby's born. Because then the baby has legal rights after it's born, because it no longer then shares legal rights with the birth mother, then the care orders can be granted, so that the local authority then has parental responsibility, meaning that the baby can then go to foster carers. A discharge planning meeting will take place on the maternity ward. So it is multidisciplinary. The social worker, a health visitor, paediatric teams, the midwives will all attend. It tends to be more around practicalities of who's taking the baby, the clothing, what the feeding plans are. The birth family are invited to attend, and they also often have been to court for the interim court order. And sometimes the police are also present depending on the nature of the circumstances. And I always find this particular time really hard for birth families. They don't have much time really. They often go from the ward because they're discharged to go to attend the courts. They may miss a couple of feeds, you know, they come back, they're being assessed the whole time, quite a stressful experience. They're out of their comfort zones, not able to behave in the ways that they normally would. And then sometimes you know, maybe very quickly afterwards attending a discharge planning meeting, feeling on show, I think, and then very quickly then the baby may be taken by the social worker or the foster carers to go and live with them temporarily. And I think that they feel, as birth family, you know, birth parents, quite underprepared really, even if they know this has been the plan for some time. The reality of it, I think, is very hard hitting. There may be a group of questions about this. Prior to the webinar, I was asked to talk about some of the jargon that's in the Red Book. So if there's anything specific that someone was referring to, if they put that in the question and answer section, then I can answer that hopefully together. But these sort of pages 1, 2 and 3 here are the pages that the midwife would tend to fill out, although I'm aware there may be some jargon in some of the notes sections which I might be able to answer. So I'm assuming some of it will be around mode of birth. So if that could go into the question and answer, that would be great. So just so aware that probably a little bit pushed for time now. Yeah, so don't want to cut us off completely from any questions that you might have. So I've put the role of adopters. I guess it's kind of where I'm coming from as well, but obviously this could also apply to anybody that's looking after a baby that's been removed from its birth family. I think taking everything into consideration and taking everything that's been discussed and everything that you already know around the in utero experience and the very early few hours and days with a newborn baby that may be suffering from withdrawal, that this will affect them longer term. It will form part of their non-verbal memory. It will form part of the way in which they express themselves and they behave. And I think from my perspective, this for me means that sometimes we have to learn to parent in a different way. So it may not be how we were parented, it may not be how our friends or how our family talk to us about parenting. This is about us learning about our child, who is very unique and is their own person. And it's simply not true to say that they come to you as a plain piece of paper or a blank sheet, if you like. That it's not true. They simply do not have the same start as others. If you've had that in utero experience versus another in utero experience where there has been optimal health and optimal well-being for mother and baby, they're not the same. It's impossible for that person to start their journey in the same place. They will be starting at very different points in life. They do begin their adoptive journey when they come to live with you, but they have some things missing. And this may be things missing in their sensory processing, in their development. It may be things missing for them on a cognition level. It may be that they have actual things missing in the brain or in other structures of their body. And it's our job to try and piece those bits together. And sometimes that's hard because you don't really know what they are. Absolutely, they have a slightly different internal working model and cannot be compared to other children their age because they may just not be there yet. And they are all very different. Please work with the children, listen to them and be curious, be fun, because laughter and love will go a long way to helping them to understand themselves, because the truth is that they don't really get it either. They don't understand why they may behave in a certain way or do a certain thing. Children who have had adverse experiences in very early life can truly learn to be very resilient individuals. They have fantastic coping strategies, but sometimes they just need a little help from us and just someone to be their voice sometimes, who can stand up for them in an adult world. We absolutely cannot change what's already happened. What's happened to them in utero and what's happened to them in the past has occurred. If there has been damage, then that damage has already happened. We also can't predict the future for our children, but I always feel that we can work really hard in the present, and that means being present for them and never giving up on them, just keeping on being there, and that's what we're here for. I have recently started a blog, which the details are on the slide, and you can contact me if you'd like to on Twitter, or there's my email.
Thank you very much. Thank you. Yes, I've reappeared. I hate it. I was thinking I've got to stop here in a minute. I really Thank you so much. Learned so much from your webinar. and lots of information to take in. Are you okay if we go straight to questions?
Absolutely, Claire, yes.
Thank you. Right, I've had a few come in already. So birth mum was on tramadol, Oromorph and codeine throughout her birth. Would this still affect the baby even though drugs were professionally monitored?
What you'll find is that teratogen, so any drug taken in pregnancy, will have the potential to pass through the placenta and have a negative effect on the baby. When you have drugs that have been monitored, then that minimises the risk because there's been a level of consistency there. So there's been, if you like, the placenta has learnt to function on a particular level, and therefore there is less likely for longer term damage. But you can never say never, in that there's never a safe window, there's never a safe amount. But of course it's always much more beneficial for the baby where it's been monitored. And if you can never assure, but if you're fairly sure that there's not been an additional drug use elsewhere, then it gives you a little bit more reassurance. Yeah.
Okay, thank you very much. Sorry, there's lots of questions. Is HELLP syndrome related to drug use in pregnancy?
No, not per se. No, it is a placental malfunction though. So it's a very advanced form of preeclampsia. So it's where, for whatever reason, when the placenta had attached early on in pregnancy around week 7, it's attached in an abnormal way, not a normal way. So the arterioles are much smaller than they would normally be. So you get very poor passing over of oxygen, so which ultimately means growth and development for the baby. What then happens is HELLP syndrome is then a complication of the mother. So she has preeclampsia, which is then superimposed with HELLP syndrome, and the letters they're all a mnemonic, which stand for different things, but it's basically a blood profile. So it's elevated liver enzymes and various other factors, which means that she actually goes into a crisis state. So it's actually very serious for the mother, but not normally typically linked to drug use, although drug users are more at risk from preeclampsia.
Thank you. How you have all this knowledge in your head, honestly. I'm whittling through these, so I do apologise. We're going to have to keep your answers short. So we need to get you back for another webinar, Jo. Hi, Jo. You mentioned in protective factors that older women were more at risk. What about very young, so mid-teenage mothers?
Well, what we tend to see is the two ends of the spectrum are where there is kind of the most risk, if you like. But when you're talking about drug and alcohol use, it's the younger is mainly because they're more likely to have more protective factors, as in their metabolism, their hormonal system is likely to be functioning better than an older mother. Also, it's about the length of exposure. So obviously a mum who's 40 may have had 20 years or more of drug abuse, whereas a teenager, 15 or 16-year-old, you hope would have had a lot less exposure. And so her body is functioning in a different way, and that otherwise she should be healthy. Therefore, we know that actually some women can just cope with higher levels of drugs and alcohol than others. But there's no way you can say that anything is safe. Younger mothers do sometimes have more medical complications.
Okay, thank you. Are you still okay for questions? Is that all right?
Yeah.
I'm aware that there's a couple rounds foster to adopt. So both of these say that it can happen really quickly once early permanence is agreed. Does the support from midwife continue? And what is skin to skin contact still recommended?
Yes, yeah, so yes to both. So what's quite sort of strange from a professional perspective is that it's usually different teams on purpose for hopefully quite obvious reasons. One team will care for the mother and one team will care for the baby. So wherever the baby goes, so if the baby goes into a concurrency placement with foster carers, or whatever that is, foster to adopt, it doesn't matter, the baby will be followed up, so up to 28 days from the midwife, and then the health visitor will take over. So yes, absolutely. And another really important thing to say about skin to skin is that this doesn't have to be the birth mother, this could be any member of the birth family, but also you could do this as a concurrent carer. It still has the same benefits for the baby, and for babies where there has been drug and alcohol misuse, it should be for all babies, but it's even more important because they will struggle with feeding and they will struggle with their blood sugars, and we know that just this simple act of putting them on your skin actually has all these protective factors.
That's great, thank you very much. I apologise to everyone, we're not going to get through to your questions because there's literally so many coming in. So we will do as best we can, but as I apologise in advance. Got some questions really which I'm grouping together around sensory issues. can drug use in pregnancy affect, you know, things like food choices, textures, the sensory?
Yeah. Yes, no, absolutely. And you tend to find that it sort of can be grouped into different things. But if you think about, the brain is such a clever organ, it's so marvelous in all the things that it can do, and it can be repaired to a degree. But there are also some drugs, particularly, I have to say it's particularly alcohol, where there may be permanent damage and that may not be recoverable. And it just depends on at which particular stage of development this occurred. But certainly, yes, there is a definite link with sensory issues. So you'll either have a child that's sort of sensory seeking, that wishes to seek out these experiences, or someone that's really avoids touch, funny with textures, funny with labels on clothes. So yeah, there is absolutely a connection. Yeah.
Or a mixture of both.
Or a mixture of both, yes.
I think. What's the risk of breastfeeding with known drug use? Is it the same as exposure pre-birth?
Yes, it is. But what we do know about breast milk is that what I looked into in terms of kind of looking at the evidence was that this really great statistic which tells us that actually where there is breast milk available, this is it leads to a 50% reduction in the baby requiring treatment for neonatal abstinence syndrome. And actually, when you just look at it very simply, you can understand why, because actually the baby is actually weaned off gradually through breast milk. So the drugs will still go through the breast milk, but it's likely to be slightly more in a controlled manner, less than they would have experienced in utero. So you get a slightly gradual withdrawal as opposed to a very sort of hard-hitting withdrawal. And of course, breast milk has other substitutes and other factors within it that offer protective factors, such as protection against infection, such as protection against allergies, antigens. So actually there is lots of good in breast milk too. The only reason to contraindicate it where it wouldn't be recommended is if there was a HIV positive mother, or a mother who was taking maybe some antipsychotic medication, if there was a lot of mental health.
Okay, thank you. I've got a kind of comment question here, really. Our foster to adopt baby was born withdrawing from crack cocaine. The birth mother used more cocaine than ever during her pregnancy. However, their baby didn't experience any symptoms. However, her brother, who was born a year before, had terrible withdrawal. Is there any rhyme or reason why that may be the case?
It's really difficult to say, because each pregnancy is again like a new pregnancy, really, and you can have the same mother having two separate babies, and that will have entirely different effects. Sometimes you find that where there is growth restrictions, so if one was smaller, they may have been more affected, because it makes fair sense that actually if they were smaller, they were getting less nutrients, so therefore they were less able to protect themselves from perhaps a baby that was better, that was well grown, and that may have been connected. It may have been connected to polydrug use, whether there was other drugs actually involved, as well as just the cocaine. So there could have been a number of factors, and you will not really know. This is the thing, there are so many uncertainties until the child's in front of you, and sort of the physical aspects are fairly easy and that they're fairly obvious, but the emotional and behavioural and everything that goes along with that are much more complex. And
it's very much like FASD, isn't it? They're still doing lots of research over some birth mothers can drink copious amounts,
yeah,
and children don't seem to be affected, where others, a small amount of alcohol causes
significant effects.
Absolutely. Yeah. I'd like to just read out some comments, if that's all right, Jo.
Okay.
That was incredible. Thank you so much. We learned such a lot.
Yeah.
Very professional webinar. Thank you. Thank you, Jo. That was fabulous. Someone here has put, we saw withdrawal 2 weeks. Jitters 3 to 4 weeks after birth in their NAS baby. However, she has developed very well, meeting all milestones. She's a wonderful little toddler, sleeps so well. So I think that's really good that.
Yeah.
Huge thank you to Jo. This has been one of the most informative webinars we have attended, and we are really grateful, professional yet empathic way this has been put across. Tonight has really been really humbling in terms of remembering just how complex both families' lives can be.
Yeah.
Thank you so much, Jo. I found that really helpful, so much experience and knowledge. Thank you very much, so informative, and thank you.
Oh, no, it's a pleasure. It's a pleasure. And I feel like I've just scratched the surface, because there's so much that you could go into. There's so much you could talk about, and there's so much more depth to it as well. And like you say, Claire, there's still so much going on in terms of research and really trying to find out exactly what may mean that someone is more at risk than others. And of course, next year we're going to see a massive change in maternity services as we see the need to then record alcohol use in pregnancy, which has not happened anything like this before. We've been recording smoking for years, and women are offered carbon monoxide testing to test the levels of carbon monoxide in their blood to look at how much they're smoking, and that's kind of become accepted now. But in terms of alcohol, that's a whole nother ball game. Because I think it's going to meet really mixed opinions. Actually, I think it's going to really divide people. I think there'll even be midwives that won't agree with doing it, which sounds crazy, but I think it's going to cause a lot of rift next year, because that's due out early next year, the new guidelines. But it's so important from families that are caring for babies with FASD. It makes the difference between a diagnosis or not, and it's huge.
It is, and the number of children in the care service that they think have FASD is a huge proportion.
Yeah, and until this comes out from the National Institute of Clinical Excellence next year, we have had zero monitoring of alcohol. It's just a question that's asked: do you use alcohol? How much? And women will normally lie to you, and if they are using alcohol quite heavily, they'll also, as this whole hopefully the webinar kind of said, they'll have so many other issues that it will be put on the back burner, because it will just be like, we've got to get her on a methadone program, she's using heroin, we've got to find her a house, she's homeless. There'll be so many other things that the alcohol will be forgotten about, really, and this will be the first time that it's really been addressed and monitored. So I mean, what that will look like in practice, I don't know, but I do think it's going to meet a lot of divided opinion.
I've got a few requests, so I'm going to put you on the spot for a follow-up webinar at another point.
Oh, yeah, of course.
So I was to discuss this at the end of that. Sorry, at the end of that, that's all right. Nothing like putting my guests on the spot, is there? But yeah, we would love to have you back. Lots of comments and lots of votes for having you back. Are we okay to send out details of your blog and everything afterwards?
Yeah, that's fine. Yeah, that's why I put them on the slide. I've only recently just started doing that. I only started about a month or so ago. It's kind of when I found out I was going to be doing this, because I thought, oh no, I'll start kind of putting things down. So yeah, it's just a little bit more about us as a family, really, and about our day-to-day life with our children.
So we will get those details sent out to everybody on Monday. This webinar will also be available, because I don't know about anybody else, but I need to watch this again because there's so much information to take in. Please do, yes, there's pleas for you to do more. So I would like to say a huge thank you, Jo. That was absolutely amazing from all of us here. Thank you very much.
Oh, happy National Adoption Week.